Hello, everyone, and welcome to HeadWise, the videocast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel. I'm the founder of Migraine Nation, and I have a history of chronic and daily migraine that began at the age of 4. I am very excited to be here today with someone many of us know and love. This is Dr. Elizabeth Seng. Hello, Dr. Seng. How are you?
I'm doing well. Thank you for having me.
Thank you so much for being here. Dr. Singh is a professor of psychology at Yeshiva University and of neurology at the Albert Einstein College of Medicine. Dr. Singh is widely published in the field of headache psychology and is just an awesome person. And pretty much everyone who watches our podcast agrees. We are lucky to have her here today. We have a topic that I really, really enjoy thinking about, pondering on, and I really believe in. We are going to talk about locus of control and how it relates to headache, migraine, chronic pain, etc. So, Dr. Singh, let's begin by just defining and discussing what locus of control is, as it's something that's discussed in relationship to everything in our world, from career to relationships and health. So, what is it?
Locus of control was originally conceptualized by Rotter in the 60s and then was also taken up by Bandura, these very famous psychologists, to describe how people view interactions between themselves and their world. And it early on in the theoretical understanding of locus of control, it was conceptualized as a single line where it would go from internal, I believe I have control over this phenomenon, over the world, over my career, over my relationships, all the way to external, where I believe someone else, something else has control over the world, over, things, over my relationship. One of the things that was noted early on about locus of control is that it does interact with some other constructs, the most important of which we're going to talk about in a little bit, self-efficacy. So from the very beginning, there was a recognition that locus of control's impact on outcomes is also going to matter on how much actual control you have. So that this has always been kind of acknowledged in this concept, which is going to become very important for us. But as locus of control went through the decades, another psychologist named Walston started to apply it to health. And he is the first person who noticed, geez, this internal to external, idea doesn't work perfectly. It doesn't really map on that way because sometimes people can have internal locus of control, but they also have powerful others locus of control. So he conceptualized people, for example, who may have a life-threatening illness or may be diagnosed with cancer. He noticed that a lot of people felt that God had control, that a higher being had control over what was going to happen to them. And that's not internal. And it's not external, but it's also not bad. He recognized that these things kind of exist together, which brings us to where we are today, where we talk about people having internal locus control. This is the idea that I am the one who controls my health and controls my health outcomes. We have chance, external locus of control. This is the idea that nothing, chance, fate, it's all capricious, controls my health and my health outcomes. And then finally, a variety of powerful others, which can include God, but often also includes healthcare professionals. So my doctor, my medicines, the medical field can control my health and control my health outcomes.
Okay, so for our purposes today, we're going to discuss something specific called headache-specific locus of control, which is a thing, and you have published on this topic. So talk to us about how headache-specific locus of control is measured and categorized.
So the headache-specific locus of control scale was developed around 1990. It's got 3 subscales and they are internal. So this is the idea that I control my headache symptoms and I control my headache outcomes, whether or not they get better. External chance. So my headache symptoms happen by chance. Nothing can control them. And then healthcare professionals is the powerful others at this scale and that we in the headache field really think about a lot. So this is the idea that my doctors and the interventions that they give me control my health, they control my healthcare outcomes.
So you just talked about what the 3 subscales are. So what does your data show about how these subscales are related to outcome in people with migraine? In other words, how we do, how we feel.
Yeah. So one of the reasons why locus of control has been so interesting is because it's surprising. In every study anyone has ever looked at, chance locus control, the idea that chance or fate controls my headaches, that they're capricious, that nothing can help me, that's always bad. It's always
Mm-hmm.
associated with more disability, even when you adjust for headache days.
Right.
It also improves over treatment. Interestingly, it improves over any treatment, drugs, behavior, doesn't really matter. If you have something that is efficacious to help you manage your symptoms, your belief that your symptoms can't be controlled or are up to fate or up to chance, that goes down. So we feel pretty confident that high chance locus of control is bad and that
Right.
that is something we want to reduce. We want people to feel like something controls your migraine disease, your headache symptoms. Headache locus control can be used across all the headache disorders, not just migraine disease. So we sometimes look in tension type headache. We sometimes look in cluster. So it's important to know that it can be generalized beyond just migraine. So chance, we're always trying to reduce chance locus control. We're always trying to give people a sense that something can help. The question is, what can help? And it turns out that that's not an easy answer because
Mm-hmm.
in many studies, both healthcare professional locus control and internal locus control, at best, they're neutral. They don't really matter. And at worst, they're bad. They're actively bad. So in some of
Right.
our studies, we've seen that higher internal locus control, the sense that you are responsible for your migraine disease and for your symptoms, is actually associated with higher levels of disability. And that really hit us and was really, really interesting to us. So the other thing that happens is that over the course of effective treatment, behavior or drug, over the course of effective treatment, internal locus of control does improve, and it improves significantly. So the question is, how can this thing that's bad improve with treatment,
Right.
but you get better with treatment too? How does that work? How
Right.
does all this fit together? So putting together findings from a variety of studies, like the basic picture is that internal locus control is only bad when you don't have tools to be able to manage your disease.
Mm-hmm.
So feeling personally responsible for your migraine disease is maladaptive if your migraine disease is out of control and you don't have a good toolbox of symptoms to help treat.
Right.
But if you have been provided a toolbox, again, most of this data come from clinical trials, right? So we're providing you with the toolbox of interventions, acute
Mm-hmm.
medications, preventive medications, behavior change, all three, depending on the trial. And then we track your internal locus control and your outcomes over time. What happens is that your internal locus control improves and it becomes less entangled with disability. So higher internal locus control is no longer so bad once you have more treatments on board and you're confident in
Mm-hmm.
using. Healthcare professionals is also interesting. You would think that healthcare professional locus of control would have strong relationships with outcomes, but it
Mm-hmm.
rarely turns out at all. And I think that a lot of that has to do with the fact that people have different relationships with their healthcare providers and they
Right.
have different interventions that they're trying to use. So again, if you have a really effective relationship with your healthcare provider and you have effective treatments in your toolbox, it's probably really adaptive to say,
Mm-hmm.
yeah, I feel pretty confident in those things that they give me, and I feel pretty confident that they'll make good decisions in the future. Whereas if that's not the situation that you find yourself in, and in many of our studies, people join them because they're not receiving the treatment that they need, then it kind of comes out in the wash and no longer has strong relationships.
So when you were talking about the internal locus of control and how it can be a negative thing, there was a word coming into my head that I'm wondering about. Tell me if I'm going down the wrong road, but it was blame,
Yeah.
self-blame.
Yeah.
Is it possibly related to self-blame? For example, I think of people who I run into who every time they have a migraine attack, they are wondering what they did wrong. What was the trigger that they failed to avoid, and it has to be their fault. Those are the kind of people I was thinking of. Do you think this could be related to that concept?
Yes. So that's certainly our working hypothesis, but I'm going to be the first person to say that we don't have empirical data. But my
Mm-hmm.
working hypothesis is that what's causing high internal locus control to be associated with poor outcomes in pretty much every study that's asked that question cross-sectionally is that there's this group of people who experience high levels of self-stigma. They believe
Mm-hmm.
these stereotypes about migraine and the environment, one of the most pernicious of which is that people with migraine did something wrong and
Yeah.
that caused the attack. And I think that
Mm-hmm.
that idea, and we may have spoken about it on this podcast before, but I think it's worth repeating. So this is stereotype. It's cultural health stereotype. That's where stigma comes from, right? And I think it comes because most people's experience with headache as a construct is not migraine disease, right?
Mm-hmm.
Most people experience headache due to caffeine withdrawal or alcohol withdrawal. So
Mm-hmm.
for most people, when they think of a headache, they think of a comparably mild pain that
Mm-hmm.
happens after they ingested something and then stopped. And at least one of those things, but potentially both, depending on who you are, have a strong moral connotation,
Right.
right? So
Mm-hmm.
I think that this stereotype is derived very organically and not maliciously from most people and cultures' experience with headache. If the last time I had a really bad headache, it was because I had a hangover, and you're telling me that
Mm-hmm.
you have a headache now, it's
Right.
difficult to understand. This is a migraine disease. This is different. This is a neurologic condition. The threshold is much, much lower. Barometric pressure, totally uncontrollable things can be
Mm-hmm.
associated with the onset of symptoms. Some people have symptoms continuously, right? It's just a completely different beast, but you can see where it comes from. So for
Mm-hmm.
people who have this strong sense of that stereotype, that I did something wrong and it caused my
Mm-hmm.
attack, that has obvious negative impacts on mood. Of course, you would feel
Mm-hmm.
terrible. It also, though, it has negative impacts on disability. You end up beating yourself up instead of being able to look forward and say, oh, my symptoms are coming. It's time for me to treat. It's time for me to do my coping strategies, to find my dark
Right.
room, to get out of the situation. When you beat yourself up, it interferes with your ability to cope in a proactive, effective way, which, of course, would then increase symptoms and disability.
I love that you said that, and thank you for that. And I would even add that I feel, as someone in the, who's had migraine since my earliest memory, I feel that that stigma comes from in our culture. It's sort of, we have this belief that you're born healthy and humans stay healthy unless they do something wrong. If you eat too much, you get type 2 diabetes. If you're stressed, you get a tension headache or a migraine. And so they always ask, oh, you have a migraine, why? And I traditionally felt compelled to just make up a reason, you know? And so I love that you said that, everyone feels like there must be a reason if you're not feeling well and it's something that you did. And I think that that's something that I think we should talk about more in our community.
It harkens back medical anthropologists who are the most fascinating groups of people that I love having individual conversations with, have described to me that it harkens back to our Puritan culture, that disease has a moral characteristic and that we are born healthy, and that if one is diseased, that implies something about one's moral character, which is obviously completely untrue, right? but
Uh-huh.
but just such a subtle thread that pulls through at least the American culture and how we think about health and disease. So I often tell people that one of the reasons why I love working with people with migraine is because they're the most resilient group of people I've met in my life,
Mhm.
because they have this episodic disabling disease that's hitting them in the prime of their lives when they're trying to work and they're trying to have kids and they're trying to go to school. And yet they still do all these things with
Mhm.
this disease. And
Mhm.
the amount of symptom that people with migraine continue to thrive with is astonishing to me.
Mhm.
And
It
so
is.
I love working with people with migraine because of the resilience. And that's such a different perspective than this moralistic, puritanical way of thinking about, disease and morality.
So my next question, getting back to originally like our train of thought here, is locus of control as a concept, is it related to self-efficacy?
Yeah. So earlier I brought up Bandura, and Bandura is the guy who made up the self-efficacy concept that has just really helped us understand a lot about ourselves in culture and ourselves in the world. And he has this amazing table that I refer to all the time, where he has locus of control and self-efficacy kind of orthogonal to each other. So one's up and down, one's left to right. And he basically says, look, if you have, we're going to assume that it's what we're talking about is internal locus control and internal, like a sense that you can do something about it. If you have a high internal locus control, but low self-efficacy, that's self-blame. You're just going to blame yourself all the time and nothing's going to get better. If you have a low internal locus control and low self-efficacy, you're just dead in the water. You don't know what to do, and nothing can help.
That's like victimhood, right?
Yes. Yeah.
Okay.
Absolutely.
Right.
Somebody else, something else. Despondency is what he says.
Right. Okay.
If you have low internal locus of control, but high self-efficacy, this one is actually my favorite. So these are the people who self-efficacy, remember, so self-efficacy is confidence in your ability to engage in a behavior.
Okay.
So if you have low locus of control, but high self-efficacy, it's kind of like, yeah, I could exercise. That wouldn't help. It's like, sure, I could try taking that drug, but the drug isn't going to do anything. Sure, I could try. So it's this almost sense of defeatism that it's like, sure, I don't need to be convinced that I could do things, but I just have no expectation that that'll help me. So really, where we want to go is high internal locus of control, or at least moderately high, like a little bit higher. Internal locus of control in his conceptualization isn't bad as long as you also have high self-efficacy. And high self-efficacy has consistently been shown in the headache field, but also in many other fields, to be a very helpful thing as long as it's a thing that you have that you can actually accomplish. Early studies of self-efficacy that many people will cite, they'll say, oh, of course you can have too high of a self-efficacy. It's true. Early studies of self-efficacy would bring people in and they would say, do you think you can play the piano? And some of them could, and some of them couldn't. So look, if you can't play the piano and you're overly confident that you can play the piano, no, that does not impact your performance.
That does not help.
Right. But what we're talking about here are things that are behavioral targets, like taking your medication, that we do think you can do, that we do think that you can accomplish. One of the places where I think the discourse around locus of control, the idea, who controls my disease? Should I think I control it? Am I blaming myself? There's a lot of conversation and confusion around that. Same thing with self-efficacy. It's like, well, so if I just feel more confident, I'm going to feel better. That seems silly. I think a lot of where the discourse totally breaks down is that we're talking about these constructs in the abstract and not in the relationship to the actual behavioral targets we're talking about. You don't have self-efficacy for migraine management as a whole idea. It's self-efficacy for, can I take my migraine-specific medication early on in the attack next time? How confident am I that I can do that? And then to what extent do I believe that my healthcare providers made an adequate decision, that this drug has the capacity to actually change my symptoms? Right. Locus control or outcome expectancies. So we need to remember that the constructs aren't pie in the sky. An easy way to think about that is with exercise. So do I have self-efficacy that I can run a 5K? You betcha. Give me the running shoes. I'll go right now. Do I have self-efficacy that I can run a marathon? Nope.
Not today.
Right? So it's silly to say, well, I have self-efficacy for my migraine management. It's like, okay, like what parts of it do you feel very confident you can do? And we all have parts that we feel less confident about, and that's okay. It provides avenues for intervention, right? But I think that's where it breaks down. We're not talking about Pollyanna-ish pie in the sky.
Right.
I'm going to think better and the thinking will magic my symptoms away. We're
Mm-hmm.
saying that changing your behavior is really hard. It's really
Mm-hmm.
hard to do new things, even if the new thing is just taking a new drug. It's hard to do that. And
Mm-hmm.
what leads us to actually do the things that actually change the symptoms and improve our lives is if we think that doing the thing will matter and we feel confident that we can do it.
All right. So again, this is possibly, it's one of, if not my favorite topic. So I have a lot of questions, but I want to know now, sort of flip side, is it also related to other things? What else is it related to? Anxiety, self-blame? What other important concepts is locus of control related to for people with head pain?
So, locus of control is intimately related with depression. And
Okay.
I think that one of the reasons why, so depression and migraine are related because they share, similar neurologic
Mm-hmm.
underlying mechanisms. They're also related because everybody listening to this podcast has had migraine disease or some other headache condition that's
Right.
disabling. That's depressing. That's hard to live with, right?
Sorry, everybody.
I'm
Yes,
so
go
sorry.
ahead.
but
Sorry to bring it up.
but in this community, we know why people with migraine will also sometimes feel depressed. Um,
Yeah.
One of the things that we don't always think about in this community, but which is worth saying out loud and which is related to locus control, is that when you have depression, one of the characteristics is self-blame.
Mm,
So that
okay.
is, if you have high self-blame and high internal locus control, that's rough.
Yeah.
That internal locus control is
Yeah.
no longer helping you. Now it's hurting you.
I just got depressed because you said that. Yeah. So
The other thing about depression
yeah.
is that it makes it hard for you to get out of bed.
Yeah.
It makes it hard for you to do anything. So that's called
Hmm.
activation energy. And that's a real thing. So when you really feel like, I know that I should do X, Y, and Z, but I just can't. That is a high level cognitive skill, the
Yeah.
starting something new. And depression really interferes with it. So much so that some people who have depression literally can't get out of bed. When you feel like even a shade of that kind of depression, it makes it hard to change new things. It makes it hard to go for the walk that you know you need to go to
Yeah.
in order to regulate your circadian rhythm and get a little bit of physical activity in. It makes it hard to eat consistently. And all of those things are associated with migraine management, and it's associated with the extent to which you think that those things may be controlling, control your headache disease. So
Hmm.
yeah, I think that it's particularly important for people who know that they're struggling with depression to
Hmm.
pay attention to the balance
Hmm.
between I feel because we don't want you to have chance locus control. That's bad. A
Yeah.
little bit of internal locus control is helpful, but we don't want you to feel so much that you have self-blame. What we need for you to feel is self-efficacy. We need for you to feel, I am confident in the tool that I have to manage my disease right now. And if I'm not, for many people listening to this podcast, you're working with your neurologist. You're trying something new and it may or may not work. And you're going to try something new in the next couple of months and it may or may not work, right? You're going through the ringer. We don't need to feel confident that this drug is going to work. What we want to
Hmm.
have is some healthcare provider locus of control that my doctor knows what they're doing and that this drug at least has the possibility to help me. And then
Hmm.
we want to have self-efficacy again, not I know this will work. We want to have
Hmm.
self-efficacy that I know how my doctor wanted me to take this drug and I feel very confident I can take it that way. That's what we want. Having higher expectations can lead them to be dashed. And then we lose
Hmm.
confidence in the system. These constructs are not about being unrealistic. They're actually
Hmm.
best when truly kind of brutally realistic about what we can expect to happen because of our
Right.
behaviors right now.
I wanted to sort of translate something and tell me if I'm getting it wrong, because a few times in the beginning, we were both using language having to do with sort of attack frequency, having control over when and if the pain and the migraine attack came, which someone like me, been like this since, had migraine daily since I was born. I personally have learned that I have absolutely no control over when, if, how bad, how often, either for myself or my child, it's going to be. The one thing I know I have control over is I'm going to continually take steps, and I am taking the right steps. And that's what I focus on. Is that also a self-efficacy and sort of a locus of control concept?
Yeah. So the idea there is that I don't have control over my disease.
And then,
So that's a low internal locus of control. This is a disease that
mhm,
I didn't cause, that I don't have a lot of control over. But you do have control over the management of your disease
mhm,
and the steps that you're going to take. And this is what the validated scales, as they're made right now, it misses some of these nuances. We
mhm.
developed the scales. I say we, 1990, I was well before my time in the field of headache medicine. But they were developed by a lab that I had been a part of, by Ken Holroyd's lab at Ohio University,
Mhm,
for a specific reason, to try to help understand change mechanisms in a specific treatment. So
mhm.
it was created in a specific context, and it's difficult to generalize it to like every context in the world.
Right.
That's why the scales miss some of this nuance. It's also important, I just want to highlight the way that we are talking about locus of control, self-efficacy right now, being very behaviorally specific. That's
Mhm,
exactly how Bandura intended us
mhm.
to talk about these things,
Okay.
because he noted in some of his early writings on the topic. I did my doctoral dissertation on self-efficacy, so I've read
Oh,
more than I would expect to on these topics.
oh, wow.
In some of his earliest writings on self-efficacy, he said that you need to ask self-efficacy not just for the specific behavior, but also its difficulty. So that's my 5K versus marathon example, is you have to know not just, do you feel confident that you can run? But what does
Mm,
run mean? Do you
mhm,
feel confident that you can take the medication that your doctor just prescribed you and then report back to your doctor how it worked?
mhm.
Yes. Do you feel confident that you can take the medication and that the medication is going to be perfect and your migraine's going to go away forever? Right? No, no. That is not a level of
Yeah,
confidence I have.
that's not in your
Um,
control. Yeah,
yeah, exactly. And it's because it's outside of your
mhm.
control. So
Right.
there are, um, it's maladaptive for me to think that I have all this control over an
Mhm,
essentially a neurologic disease that I'm struggling with, that my
right.
own behavior only matters a portion. It's also important. Okay, I just want to take it one step further for
Yeah.
people. So there are going to be people right now who are thinking, well, I control when I get my migraine attacks because if I skip a meal, I get a migraine attack.
Mm,
I have control over my migraine
right.
attacks because if I have a terrible night's sleep, I stay up too late, I have a terrible night's sleep, then I know that I'm going to wake up with a migraine attack. So,
Mhm,
I know that I have more control. And I just want to gently suggest that we may have less control over things like our appetite than
mhm.
we assume. We assume that we have like perfect and complete control over our eating behaviors. But if that
Right.
was true, we would not have an obesity epidemic in the country, right? We
Right.
assume that we have all of this control over our sleep. But if that were true, we wouldn't have an insomnia epidemic in this country, right? So
Yeah.
there are a lot of things that we feel like, because our own behaviors and decisions do matter, that
Mhm,
therefore entirely in our control. And that's not just
mhm,
accurate. Our symptoms are this complex interaction between our brains and our behavior, and our brain impacts our behavior too. It's not just one
mhm.
direction. So my message is always like, give ourselves a little bit of grace.
Right.
But in this context, my message is also try to like self-examine your control beliefs a little bit, because you may surprise yourself.
Mhm,
Try to examine a little bit over, am I really blaming myself for my migraine disease?
mhm,
Or do I have a lower internal locus control there? On the other hand, do I believe that I am the one who controls my migraine management? Or am
Mm-hmm.
I have low internal locus control there? Am I having an expectation that the doctors will figure it out, or that, something else is going to have to change? Some level of internal locus control allows us to build self-efficacy and to
Right.
build the skills and tools that we need in order to get better.
So I have just a couple more questions that I think will help people maybe intervene on themselves if this is a concept that they're interested in working with. In your estimation, what do you think is the healthiest balance of headache specific locus of control when it comes to the three? Just we've hinted at
Yeah.
this with a lot of words, but if you were to summarize for someone with
Yeah.
migraine, what is the healthiest balance of the three?
So I think that, and this is clinical and not empirical. It's clinical informed by empirical, but I think
Mm-hmm.
that we should have a pretty low internal locus control when it comes to why I have migraine in the first place.
Right.
All right. But I think that we should have a moderate to high internal locus of control around I can do something now to reduce how much symptom I have. And
Mm-hmm.
that's where we then look to self-efficacy and say, what are the things that I can do? And
Mm-hmm.
which of those things am I confident in? And which am I less confident in? How do I get more confident? That,
Right.
I think, is the best strategy. We always want low chance or fate locus control. Like,
Okay.
migraine is a manageable disease, and the belief that it is solely due to chance or fate is just maladaptive in every circumstance, and is something that we should strive to identify in ourselves and identify alternatives. For healthcare professional locus control, I think that it's a really great indicator of the extent to which you have a productive relationship with your healthcare provider. Remember that
Right.
healthcare professional locus control, we don't expect our healthcare providers to be our saviors, and
Mm-hmm.
we don't expect them to do all of the work for us. In fact, in migraine disease, and especially, we need to take the tools they give us, go home, and try to implement them in our lives. But we should have a moderate belief, at least, that the tools that I'm being provided with by my healthcare provider could help me. And that if these
Right.
tools don't, my provider will help me find tools that will.
Right. Okay. How about, are there results if someone were to go take the headache specific locus of control test, for example? Are there results from that test that can be seen as a warning sign? I, by the way, did go take it before we did this episode, and I found it a little bit interesting and I was a little surprised by it. Can there be results that would be seen as a warning sign where a person would want to look at themselves and perhaps work on changing certain thought patterns?
Yeah, if you are finding that you're endorsing a lot of those chance locus control items,
Hmm.
nothing can help me.
Hmm.
Nothing can change my migraine. My migraine is up to whims. It's up to fate. That is a really good indicator that you want to think a little bit about your migraine management plan. You
Hmm.
may, if you're not already on prevention, you may want to really strongly consider, it doesn't have to be a drug, right? But you really may want to strongly consider some type of prevention. And you might want to consider seeking help from mental health provider.
Hmm.
Obviously, there are those of us who work with headache disease, and that's great. But pretty much any cognitive behavioral therapist, anywhere,
Yeah.
there's plenty of them.
Hmm.
If you can come and say, look, I'm struggling with this, with a chronic illness,
Hmm.
and I was taking this test, and it really showed me that I am really struggling with feeling like there's nothing that I can do and everything's just going to get worse. Can you help me
Hmm.
with that? That is a something that you may be surprised. Again, I do not think that changing the thoughts alone is what changes migraine disease and migraine related disability at all.
Hmm.
I think that our thoughts are the avenue by which we act,
Hmm.
and that it is difficult to manage disease when the person in your head is talking to you all the time saying, this isn't going to matter. Why are you even trying? This is silly. Stop trying. Just go to bed. If
Hmm.
that person is saying those things. Of course, it's going to be harder to do the
Right.
things that you want to do. So changing your thoughts is not this magic way that symptoms change. Symptoms change through management behaviors and using tools.
Okay.
But man, some of those thoughts can make doing that a whole lot easier and a whole lot harder.
Right. Our thoughts can be blocking us. As
Yeah.
yes, yes. So is there anything else? That was awesome. I really loved this episode. Thank you so much. Is there anything else you'd like to add to this topic before we go today?
As always, I just want to make sure that I emphasize to everybody listening that your migraine disease, your headache disease is not your fault.
Mm-hmm.
And at the same time, there is a lot that we can do to try to help you feel better.
Mm-hmm.
And more than feel better, there's a lot that we can do to try to help you get to your kid's next soccer game or to get to the events in your life and the pieces of your life that are important to you to improve your relationships with people. So if you have found yourself in your migraine journey where you're no longer engaging with a healthcare professional around migraine because it's just been so overwhelming and disappointing, I would ask that you use this episode to consider re-engaging, to consider using some of the resources from the organization to find a headache provider in your area. And if you're struggling with some of the stuff we've been talking about, to try to maybe even find somebody who does CBT for a couple sessions to see if there's ways maybe that we can think about migraine a little bit differently. We are not to blame for the symptoms, and there is hope.
Right. Thank you so much, Dr. Seng. That was just an awesome episode. That was so fun. And I hope everyone got something out of it. And thank you, everyone, for joining us today. Please join us for our next episode of HeadWise. Bye-bye, everyone.